Good morning. Thank you for having me here. My name is Padmaraj, and I'm presenting a case of a 31-year-old female with bad luck. And as I present, you will know why this title. First, we have a 31-year-old fairly healthy female who went to hiking, and in that process, hiking, camping, and in that process, she did not renew her insulin prescriptions. And when she came back from there, her husband, who went out to get the prescriptions, found her to be unconscious, heard a third sound, and him being an emergency medical technician, he starts CPR and calls 911. And the patient is brought in. The patient had a fairly prolonged cardiac arrest, close to 1 hour, before the patient could get a return of circulation. The labs are demonstrated here. As you can see, notably, the glucose is very high, 695. Fairly elevated, anion gap, bicarb is less than 5, and anion gap is more than 30. pH is less than 6.8. Troponin is only 2.7. For some reason, every patient gets a troponin, but in this patient, rightly so. The ECG is demonstrated there, basically shows sinus tachycardia, right bundle, right axis, and ST segment elevation in V3 through V6. There was this concern whether this ST segment elevation is this because of acidosis, this is really MI in young patient. An emergent bedside echocardiogram was done, which kind of went for some few seconds here in the slide, and it basically showed the anterior wall was significantly hypokinetic. The patient was emergently taken to the cath lab, and of course, we find that her ostial LAD is completely occluded. There was a large amount of thrombus. LV gram was confirmed extremely low performing left ventricle. And an intervention was done to the ostial LAD with support of an Impella catheter, Impella device. Stenting was done, and aspiration thrombectomy was also performed. And by the end of the case, the patient had a TIMI2 flow. But while this was also being done, right heart catheterization was also performed, which showed right atrial pressure of 16 mmHg, PA pressure 33/23 with mean of 27, and cardiac output of 2.21, but that was on rocket fuel, epinephrine and norepinephrine. And wedge pressure was 19. Well, return of circulation is achieved, everything is better, the patient is doing well, and the next day, the patient wakes up. This is her bad luck number 3 now. The patient being persistently hypertensive, a bedside echocardiogram is done. It shows pericardial tamponade. Very reluctantly, the patient is on dual antiplatelet therapy on Impella device, so she is on heparin for anticoagulation. Very reluctantly, pericardiocentesis is performed, which basically shows the patient has a chylous pericardial effusion. So this is fairly rare, and chylous pericardial effusion causing pericardial tamponade is farther rare. So that's bad luck. Then the patient has the pulseless electrical activity the next day. That's the 4th bad luck she has. She has an ECG which kind of shows almost same distribution of ST segment elevation, but has some more additional ST segment elevation in V2. So she's rushed to the cath lab again. We don't find anything. Well, why did that happen? Kind of was unclear, but because the patient was hypoxic as well, she was upgraded to VA ECMO. And in ensuing few days, she was found to have MSSA in sputum. So suspicious was, hey, is this pneumonia? Additional ARDS going on? But she's on VA ECMO. Now, things should get better here now. Bad luck. So she has an Impella in her left ventricle, VA ECMO, and she has her 5th bad luck. She has an surveillance echocardiogram which shows apical thrombus, and you're thinking, hey, is this because she has an Impella in the left ventricle? Was it causing endocardial injury and and the ECMO causing high LVEDP, low flow state? So she has that LV apical thrombus. Well, she had an ECMO weaning trial for about 9 to 14 days, and because her left ventricle filling pressure was very high, there was some debate about whether or not to remove Impella. Impella was not removed, it was kept there. The patient did not have any neurological problems with that. Every day we would have our fingers crossed. For a few days, ECMO decannulation was tried, and then on day 15, the ECMO was decannulated, and she was placed on HeartMate 2. LVAD, and the usual parameters, 8200 RPMs and usual flow. Well, few more bad luck, and then we have an answer. She had acute right femoral limb ischemia, for which she required a right femoral thrombectomy. A large thrombus was removed. She had a repeat thrombectomy on day 18, and by this time she was, we're realizing she has clots everywhere, and some smart person had sent out an anticardiolipin antibody, and by now we had the diagnosis of probable catastrophic antiphospholipid syndrome. Well, she had 5 rounds of plasmapheresis because of catastrophic antiphospholipid syndrome, and on day 44, she was discharged successfully, and currently she's being maintained on 2.5 to 3.5 of INR on warfarin therapy. So that's my case.
So this is an excellent case, and although there's a lot of bad luck, I think the lady is also in some good luck, because my guess is that she survived the whole
True, but some of the heart transplant people were also saying she was exposed to a lot of blood products and young patient, future heart transplant capability. So
perhaps there are some. Ali, why don't you just take a chair and go and sit here? Because let's give him a chair.
It's the endowed chair. If you have the case again, what would you have done, or what you would do different? If you have the similar case coming to you next week, what would we do different?
That's a great question. So what we have, at least what I have personally learned, is that in an unusual case, you have to think of zebra diagnosis, basically. We all thought of HIT, and we all thought of TTP. Those were ruled out. Catastrophic antiphospholipid syndrome typically did not came to my personal differential, but now it will. And any person who's having too many clots, I will keep that differential in up front, and maybe therapeutic plasmapheresis prophylactically.
I have a comment. While you were discussing this case, and there was a thrombus on the left main, and then the intraventricular thrombus, and then the chylothorax. We were discussing here. I mean, there is some prothrombotic issue going on here, and I think the educational point here is this patient needs to be worked up, especially before going to durable ventricular assist device, because luckily she did well, but we have cases, that I can remember one case of very prothrombotic issue. We put an LVAD, and this patient ended having a big clot in the root, and it thrombosed the ventricle, and it ended really bad. So anything that is telling you, 31 years old, clot in the left main, clot in the ventricle. I bet you that when the Impella was on, the heparin was going in. So, this patient was anticoagulated, and despite of that, is just making clots. So
true, but the patient was not meeting the criteria for catastrophic. It was at that time probable. And then while the patient is on VA ECMO, therapeutic plasma exchange would have been a big decision. And I think that caused some element of delay, but that thought process was started. Anticardiolipin antibody was sent. It took about 20 days before the diagnosis could be confirmed.
So this reminds me of a case series by Martin Struber that's very important for us who want to try to individualize care. Excellent case because of the setup that you gave us to, is it bad luck or is it, not, we have to think about these things. The pre-diagnosis of the antiphospholipid syndrome, I think, is important. We've made that mistake twice, and one person survived, the other did not, due to pump thrombosis that we explained later after we had to talk to the family and say that that's what the patient had. But Martin does describe, when he was, I think when he was at Hanover, 2 or 3 cases that he pheresed successfully. I mean, in Germany, there's a very, aggressive, they didn't turn these patients down. 2 or 3 cases pheresed successfully with some other therapy for antiphospholipid syndrome.
Yeah.
Probably, and they did well. Now, again, case series are presented that are doing well. Maybe the ones that didn't do well are not. But I think it's an important point you made about the workup and having a low threshold, because ultimately you're going to commit a 31-year-old to a VAD. The other question I had is, did you check the triglycerides? Were the triglycerides really high?
I'm pretty sure, I don't remember top of my head, but any patient who comes with STEMI, they have, lipid levels and all those things.
She had a hyperglycemic response, and she may have been in a ketotic state with she could have thousands, and then you can freeze that as well, and that could help.
That's exactly what I was about to ask. But two things in your slide. It was a great case, though, the way you presented it, and I think we have probably made the same mistakes or the right thing what you did. But I agree with him that putting a durable LVAD in this, you may have won the battle. I don't know, the war is over yet. But more importantly, your slide 3 times showed refractory hypertension, but you were on full doses of milrinone with norepinephrine epi. We would try to usually come down on milrinone when there's a refractory hypertension.
That is correct, but from what I understand, the advanced heart failure physicians were thinking in lines of RV failure also at that time, and for that reason, milrinone was kept, and dosage were titrated based on the PA catheter numbers.
Can
I'll
I just-
mirror what you said, which is that we may have won the battle, but not necessarily the war. Anticoagulating somebody with an INR of 2.5 to 3.5 for severe endocardial lipid antibody syndrome in the setting of VAD is precarious at best. So my recommendation going forward would be to have some surveillance plan about how you're going to measure their anticoagulation / thrombosis potential going forward.
So although there is no data on catastrophic antiphospholipid syndrome, there are some case series on patients who were discovered to have antiphospholipid syndrome after the VADs were placed in, and the approach is typically not different. It's the same level of
The old men around here have actually seen, and old ladies have actually seen these patients stay thrombose.
Can I ask a quick question?
Sure.
I'd be interested in hearing from the panel what their institutional experience is and practice as far as screening patients before durable VAD for thrombophilia. Because I know that, especially when I was at Pitt as a fellow, they would routinely screen everybody for the common types of hypercoagulable states before VAD. What do you guys do at your institutions?
See, there is no guidelines to that. Actually, if you see the American Society of Hematology, they discourage you to do a thrombophilic workup because of the insensitivity of the test in picking up thrombophilic states. But you just have to be bitten twice. And I'm sure any program which has, like you said, you've lost 2, we have had our share of failures with patients who obviously we would have picked if we had screened them. One was a sickle cell disease, and one was a prothrombin gene mutation. We have started routinely doing that. I wouldn't say that we have picked up someone so far since we've been presenting who had a thrombophilic test positive and we declined it, but I'm sure we'll find one of those.
Back when the HeartMate 3 was in trials, it would exclude HIT. And so when I was in Newark, we used to actually routinely send a PF4, although that can certainly fool you and take you down the wrong path. But we used to screen for a lot of things. The problem is you look at asymptomatic patients, exactly as I said, sometimes you find things that aren't real.
Thank you so much for that.